I'm John Strum, and this is Real Talk MS. It's October 28th, and we have a lot to talk about. And today we're talking about access to medications that can sometimes change the trajectory of your MS journey. In just a few minutes, I'll be giving you a heads up about some new witchcraft that might make it more difficult for some of you to get the disease-modifying therapy that your neurologist or MS specialist is prescribing for you. Later in today's episode, you'll meet my guest, Cassandra Ashby, who's going to share her family's adventure trying to get the treatment prescribed to Cassandra's daughter, who had been recently diagnosed with MS. I know Cassandra's story will resonate with many of you. It might even sound too familiar, which is truly unfortunate. It makes this ongoing, untenable tug-of-war between insurance companies and patients all the more sad. But before we get to my conversation with Cassandra, there are a few other things that you should know about. Results from a study just published by a research team at the University of California, San Francisco could change just about everything when it comes to diagnosing and treating MS. The study shows that myelin damage actually occurs 7 years before the first MS symptoms appear, and about a year before that damage even becomes apparent. Understanding that MS begins years before its clinical onset opens the door to developing treatments to prevent MS, or at the very least, stop MS before it has a chance to do further damage to an individual. Now, as a quick review, myelin is the fatty sheath that surrounds nerve fibers and facilitates communication throughout the nervous system. In MS, inflammatory activity damages myelin and damages the part of the nerve cell that conducts electrical impulses, that communication between cells. The interruption to that communication is what causes MS symptoms to develop. And MS is diagnosed when imaging reveals that myelin damage. But that damage has already occurred. And that begs the question, when does MS actually start to damage the nervous system? To try to determine that, the UCSF research team analyzed data from 100 people who developed MS after enrolling in the U.S. military. Thanks to a Department of Defense repository, there were blood samples from these 100 people that were taken years before they were diagnosed. The research team also included data from healthy people who didn't have MS, as well as data from other people with MS that was available from other databases. This analysis showed that a specific myelin protein spiked about 7 years before the onset of MS symptoms, and a spike of another protein that we've often discussed on this podcast, neurofilament light chain, occurred about 6 years before symptom onset. It's worth noting here that neurofilament light chain is released into the bloodstream when nerves are damaged. Analyzing the levels of a third protein called GFAP, the researchers also determined that damage to astrocytes, these are the brain cells that help support nerve function, well, that damage occurred around the same time that MS symptoms became apparent. All of these measurable events in the central nervous system allowed the research team to construct a timeline for how MS develops in the years before it becomes apparent. And here's how that research could impact MS care. The researchers explored whether some of these proteins, seen as biomarkers of MS activity, could be used to detect MS in this pre-symptomatic stage. And they found that a model using 21 of the proteins could accurately identify 79% of the MS patients while they were still in that pre-symptomatic stage. And that's worth saying again. They developed a model using a blood analysis that could identify MS years before someone developed any symptoms. And they could do that accurately 79% of the time. I consider that a pretty strong batting average. The team has already submitted a patent application for a diagnostic blood test that could be used to detect MS years before symptoms develop. And who might benefit from this? Well, most every adult living with MS that I know has worried about whether their children might develop MS. Imagine a child of a parent with MS getting a simple blood test that, if the results came back positive, would allow an intervention with high-efficacy disease-modifying therapy years before MS symptoms even develop. Might that child live a life without ever experiencing a single MS symptom? Well, it's a question that's definitely worth answering. If you'd like to review the details of this game-changing study, you'll find that link in today's show notes. ICD-10 stands for the 10th revision of the International Classification of Diseases. It's a standardized and consistent language for health records and communication between healthcare professionals worldwide. It's used to track and analyze health trends and statistics, and to facilitate healthcare billing and reimbursement. The system was developed by the World Health Organization and first published in 1993, and the U.S. adopted this system in 2015. Healthcare professionals use these ICD-10 codes to document a patient's diagnosis, treatment, and any procedures they may have undergone. And insurance companies use these codes to process claims and determine payment. And the reason we're talking about ICD-10 codes is because this month, the ICD-10 codes were updated, and that update introduced major revisions to multiple sclerosis coding that may determine whether insurance companies continue to approve the disease-modifying therapies their insured patients have been on for years. Since ICD-10 was first implemented in the United States in 2015, MS has been captured by a single code with no further distinctions. However, in the most significant expansion of ICD-10 codes in recent years, beginning October 1st, the MS code has been expanded into detailed subcategories. The new ICD-10 codes for MS now include these specific categories: relapsing remitting MS, primary progressive MS unspecified, primary progressive MS active, primary progressive MS non-active, secondary progressive MS unspecified, secondary progressive MS active, secondary progressive MS non-active, and multiple sclerosis unspecified. Just a reminder that the term active refers to clinical relapses, new MRI activity, or progression requiring therapeutic intervention. And the term non-active refers to disease stability without recent relapse or imaging changes. And this is where one of the big problems could lie, because patients and their doctors know that someone can be experiencing progression without relapse or a change in their MRI. So where do they fit? Well, that's a gray area. And we know how insurance companies love to hide behind gray areas and deny treatment. I've been able to confirm that this has already become a problem for some people with MS who are expecting their next Tysabri infusion, only to have their healthcare provider begin the unpleasant, time-consuming exercise of fencing with their insurance companies over a denial letter. And this is denying treatment that in previous months or even years had already been approved. So as your neurologist or MS specialist submits the next prescription for your DMT, even if it's the same one you've already been taking, just be aware that it could require a bit more of that familiar back and forth between your healthcare provider and your insurance company before that prescription is finally approved. I want to remind you that tomorrow, October 29th, is your opportunity to be part of a historic meeting. From 10 a.m. to 3:30 p.m. Eastern Time, the National MS Society is hosting the Shaping Tomorrow Together externally led patient-focused drug development meeting. And if I can add some clarity to those details, this meeting is designed to allow people affected by MS to share their experiences and perspectives with the U.S. Food and Drug Administration. This is an opportunity for the patient community to pinpoint gaps in current treatment options and, most importantly, inform researchers, clinicians, the FDA, and those companies in the business of developing treatments for MS about the biggest challenges still facing people who are living with MS. The meeting's going to be live streamed on Zoom, and I hope you'll be watching from your home or office as the day unfolds. You'll find the link to register and join that meeting in today's show notes. While this meeting won't reform the insurance industry in the United States, I imagine it's going to be hard for some people living with MS not to point out the reality of gaining access to the disease-modifying therapy that they and their neurologist have determined is best for them. It's not always the simple matter it should be, as you're about to hear when you meet my guest, Cassandra Ashby. Having more than 24 disease-modifying therapies available doesn't mean that they're available to everyone. In the United States, insurance companies are most often the gatekeepers to prescription medications, and those companies rely on pharmacy benefit managers, billion-dollar companies that operate with no oversight or accountability. In fact, most people have never heard of these companies, but they're the ones that determine which medications an insurance company is going to cover. You're about to hear a story that in one form or another is familiar to many people living with MS, who discover that once their neurologist has written a prescription for the disease-modifying therapy that they believe is the best choice for their patient, that's where the game begins. My guest today is Cassandra Ashby. Cassandra is a quality improvement nurse at a major healthcare organization. And Cassandra's daughter, Kara, was diagnosed with MS just this past year. Welcome to the podcast, Cassandra.
Thank you, John, for having me. I really do appreciate your platform and allowing the story and the other stories that are being told. It is very important.
Kara was diagnosed. She's seen by an MS specialist at the Cleveland Clinic, and her doctor prescribes Ocrevus. You check and discover that Ocrevus is covered by your insurance. What happens next?
Sure. Well, yeah, there was some footwork done prior to make sure that this was a good plan for healthcare through her new husband, because she was going to get new insurance. The very first part of this was a little disturbing because the health insurance company, when she became eligible to be on the health insurance, they lost her information and it took months for her to even get on the plan. So we have a problem there. And then come January 1st, she did become eligible. So we have to start at January 1st now. January 1st came and there was information back and forth between Cleveland Clinic's, I guess, advocacy or case management or infusion therapy center, and they do the work with the outreaches and the pre-approvals. So they did go ahead and started that. And apparently there had been some problems with that. A long, lengthy delay in between communications. Oftentimes the PBM or the third party or whoever was involved, because that ended up being like 3 entities for Cleveland Clinic to be communicating with, and nobody seemed to know what they were doing and couldn't find paperwork was another problem. And oftentimes they would say they have faxed information to Cleveland Clinic, and that wasn't also being noted that faxes were received. So this kind of went back and forth a couple of months. My daughter got involved with a case management person that reached out to her by phone and engaged her in case management to help her with her MS and getting her treatment. During this process, we felt that the person was more of a gatekeeper to the Ocrevus medication. Okay, so from January to April, communications between Cara, Cleveland Clinic, and the other vendors, or we call them the gatekeepers. It was a delay process of mixed information that really wasn't making sense. My experience with case management and assisting members getting their benefits, their medications, I've never seen anything like that before. So I thought it was odd when the case manager asked Cara to go ahead and leave Cleveland Clinic and go to a small clinic, and she would get her medicine there. They didn't tell Cara where she would get it, but they were trying to steer her away from Cleveland Clinic, and it's still unknown why. There are some theories behind it because of the PBM that she has is actually on the radar for possibly bringing in some medications from out of the country. I'm not sure if you're aware of that, but that is something that I have been told is on the radar. And so they're trying to bring in cheaper drugs also. So we're not sure if that was one of the strategies they were pulling on her. We have not been able to find out.
But meanwhile, months are going by and your daughter's not being treated, correct?
She is waiting patiently. She had asked the case manager to quit calling her because it was very disturbing to her emotionally because there was no results. It was just delay. Also very odd because there was no paperwork that came to her that said she was in a case management program. In fact, she never received any documentation of her medication being denied or approved.
So just to underscore that, for several months, there was no treatment and there was no written documentation as to whether it was coming or it had been denied. Is that correct?
Yeah, she was in the dark, kept in the dark. Very disturbing, actually, knowing that MS is very disabling disease, and I seen how she was in her attack. So it was getting a little odd that it was going on so long. So I did speak to Cleveland Clinic with Cara, and I asked there is an expedited process that could be used to help get the medication faster. So I asked for that to happen, and nothing was expedited on the PBM's behalf. I'm not sure how these PBMs work. So during this time of delay, she ended up having an MS relapse, which did cause more damages and medical expenses to her and her family that she can't afford. It's been very traumatic experience for her. And we still don't know if she's going to get Ocrevus or not. She ended up getting pregnant right before the Ocrevus was going to be administered. We did get a date, but I am uncertain. This is how confusing it is. And I'm still working out a lot of details. And we do have proof she was denied by a voicemail message through one of the PBMs or the case manager, but now the PBM says she never got denied. So nobody's coming forward. Nobody's giving us any documentation that we've asked for on the PBM side. We just have the voicemail messages that the case manager left behind for my daughter after my daughter told her not to call her anymore. So this case manager was leaving her pretty important information that really has sparked a big interest of what is going on with these PBMs and getting access to Ocrevus. And then my understanding is that Ocrevus and the new standard of treatment doesn't appear to be followed through these PBMs, where when you are diagnosed with her being fairly new, the treatment is to hit it quick right away and with the best for the outcome. She's 28 years old right now. She just finished her college education and a bachelor's degree in human resources. She tried to go back to work. She spent all this money on education. trying to go to work, and it didn't really work out for her. She has a debilitating situation, and she's not even in a position where she's balanced yet to even probably be on her feet to work and make a living and follow the dreams and the goals she had. I feel like she's been limited by the money that the PBMs are saving the insurance. I'm not going to say insurance. I'm going to say the employer group, because it is an employer plan that is being targeted by these PBMs to save money. So these PBMs come through these insurance groups like your unions, your municipalities, fire stations, school districts. And they come in and they're designed to create cost savings for these employer groups.
Let me ask you a quick question, because you said something a moment ago, and I think it relates to the cost savings you're describing now that usually do come at the expense of the patient. Did your daughter receive any information that she should actually start on a different drug than
No,
Ocrevus?
she didn't. I'm glad you brought that point up, because the PBMs never let Cleveland Clinic know. They didn't let Kara know that there could be an alternative while we're waiting. There was nothing offered, and there's no paperwork. We're looking for the trail from these PBMs, and I'm trying to find these loopholes, which I think I found one. Maybe. We'll see. I've gone through a lot of avenues. Being that I do have some insurance background, it is very difficult. I was not aware that these problems were happening. So I feel like I've been very blindsided and slapped in the face. And if I knew, I probably could have done better.
So I should point out to our listeners that when you say you have some experience, Cassandra is actually in the business, and we're not going to be more specific than that because we don't want to get her in trouble with her employer. But when she says she has experience working with these entities, she's not speaking strictly as you or I might say that as a patient trying to get coverage. But
so when I was told found out this was happening, one of my statements was, this is a 27-year-old woman who is a new mom too, a hardworking woman who is about to start participating in an employment and paying taxes and doing the hard work of an American dream. And it seems like that was ripped out of under her. And if she doesn't get the right treatments, will she be disabled? And then will she be having to make decisions of needing to go on disability and possibly a Medicare plan in 2 years where the taxpayers pay it? That's another perspective that really bothers me. She hasn't had any work credits. So this just doesn't make any sense. Why would our healthcare system allow this to take place? And my understanding, this is happening to other MS victims as well.
You're right. And your confusion is not so unique. Excuse me. Your confusion is not so unique. I wish I could say I've never heard this story before, but oh my goodness, I know we have listeners right now who are rolling their eyes as they hear your story because it's all too familiar.
I started my career in nursing when I was 15, 16, started at all these different levels and worked my way up. And my first MS victim that I saw, I call them victims. I'm sorry. They're patients, but to me, they're victims, was in California. And that's where I had my biggest experiences, started in there. And they were siloed, left alone, no help, no treatment. I really thought we have come a long way, because I know when I did case management, when I saw an MS member, I always inquired how that was going. And at that point, Ocrevus was available. Now, but we're talking a line of business called Affordable Care Act. And apparently they didn't really have any problem getting the medication. So I didn't really think my daughter would have a problem. Now, come this year, my daughter can't access it. A lot of people with insurance can't access the medicine. You can be disabled so quickly with this disease because it's a snowflake. It's not a one size fits all. And it really bothers me to hear that PBMs are not allowing these specialists who are trained and know what they're doing. And I took my daughter specifically to one of the best in class because I know quality matters when you're dealing with a disease.
You're absolutely right.
And,
I'll say that
right.
The neurologist treating your daughter is one of the best in the world.
Yes.
And so you picked the right person. And apparently that person picked the medication they felt was most appropriate, that's going to be the biggest help to your daughter, to keep her active,
right.
to avoid progression, to do all the things we take that medicine for.
Yes. When we left that visit, that first visit, we felt so good and just, wow, like I didn't realize like MS had come this long of a way and there's all this hope. And so it was rather exciting to know and a relief that my daughter and MS victims have a real chance at living a good, long, successful, happy, healthy, loving life. But at the expense of the profits that are needed or desired by these PBMs are designed to not have that available, that access is blocked. And it's really important about getting the medicine at the right time, the right medicine, right time. There's just no question. There's nothing to negotiate about it. It's very clear. And when is this going to stop?
I have some good news in the long term, and that is that the Federal Trade Commission has filed a lawsuit against several of the largest PBMs in the country. And at the same time, Congress has opened a congressional investigation and subpoenaed information, all sorts of documentation from several pharmacy benefit managers. And I will even go further and say this is one of the very few issues that we see in Congress today that's completely bipartisan. Both major parties are committed to figuring it out, to shining a light, to creating some transparency, because as I said when I introduced you, most people have never even heard of a PBM. They know their insurance company and they know their doctors, but they don't know who stands in between their insurance company and their doctors. And these are, as I said, multi-billion-dollar companies. And it's time that we applied a little oversight, and that will change things.
I agree. These employer groups, they don't realize they're going to be losing their valuable people because they're going to be taken down by the disease, and they're not saving money. They don't probably realize they're ruining lives by allowing these PBMs to come in and convince them they can save them money. It's not real.
So here we are. It's been more than a year since your daughter was diagnosed. She still is not receiving a disease-modifying therapy. Is that correct?
No. She actually is receiving a DMT while she's pregnant. Her doctor did prescribed a DMT, and that took a little while too to get through the same PBM. But she did finally get the DMT. And so while she's pregnant, it will help protect her at this point because pregnancy does. So this will be a little added protection. So she is working with her specialist with a strategy for pregnancy, and she's doing really good with her pregnancy. And so after birth is going to be a critical point. And then there is a plan in place working with her specialist after delivery to get to her prescribed DMT, Ocrevus. And I really hope to see that it's going to be timely and the PBM just does their job and allows my daughter access to her MS treatment. And so my daughter doesn't have to have any more brain lesions, or what is it? I think 80% chance of it working. That's a high chance. My husband had a heart surgery that was an 80% chance of working. Well, the insurance paid for that. That was just a couple months ago. No questions asked. But that's not a pharmacy.
Cassandra, I want to thank you once again for being willing to share your story. I think, as I said, there are going to be some listeners who roll their eyes and simply shrug their shoulders and say, of course, I get it. And there will be others who are going to be warned about how things could go. Thanks again for joining me today.
Thank you.
That's going to wrap up this episode of Real Talk MS. Real Talk MS is powered by the National MS Society. And you can share this episode of the podcast by letting your friends or family members know that all they have to do is point their web browser at realtalkms.com/426. You'll find that link in today's show notes, so you can easily copy and paste it right into an email or a text. Getting on and staying on a disease-modifying therapy is the foundation of MS care. DMTs delay progression, and that means enjoying a better quality of life longer. But evidence also shows that making the right lifestyle choices can absolutely improve the quality of life for someone living with MS. Next week, MS specialist Dr. Barbara Geiser joins me to discuss how some very popular lifestyle habits like smoking, alcohol, and caffeine can impact MS. I hope you join me for what could be a life-changing conversation. I'm John Strum. Thanks for listening. Stay safe and make healthy choices.